Good afternoon, everybody. Welcome to March office hours. Wanted to thank you all for joining today. We'll get started. I know we got some folks still popping on, but we want to get going so we can get everybody back to their afternoon. So we'll get started here. We'll do our normal agenda of policy and procedure updates, children's NetSmart updates, talk a little bit about CESTOOL, guidance update, MAP, plan of care status update, and then budget advocacy update for folks. As usual, we're recording this session just so folks have the ability to reference in the future on our webpage. As always, if folks have questions, please feel free to chime in along the way or use the chat function. With that, we'll get moving forward. Jessica.
Hello, everyone can still hear me, right? Travis?
Yes. Yep,
Okay,
gotcha.
perfect. So policy and procedures that we're going to go over today, we have care transitions, HARP oversight, health home billing, health home plus for SMI, incident reporting, and our notice of decision and fair hearing. And then a couple of updates that we have coming are going to be the health home serving children, HCBS, adaptive and assistive equipment, EMODs, and BMODs. And also we're going to be updating our eligibility and appropriateness criteria policy for some updated language around the cesspool. And that will be forthcoming, but that guidance has already gone out to use the enrollment month or consent date to do those cesspools. You can go to the next slide. Care transitions policy, there were no updates to this policy. It was an annual review. Just a reminder moving forward on all of our policies that are going to be updated over the course of the last 12 months. We're going to be including where we are pulling the policy from. So we're going to include the policy number that DOH gives us or the health home standards that's included. There's also updated language in there about if you have any questions regarding the policy that you under scope, that's going to be number 2, that you then follow up with myself or whomever the designated person is for the policy. And also all policies are back to being reviewed by our compliance officer. Next slide. HARP oversight policy. This was an annual review. We did update one portion of this policy to include updated language for the adult HCBS form in NetSmart. Anyone who is enrolled in HARP and who has an active HARP service, so they're actively connected to HCBS, you want to make sure that you are completing that HCBS form in NetSmart. That makes the frequency, scope, and duration for the HARP plan of care actually generate on the health home plan of care over to the Department of Health. So this is for only if you have a HARP member who is actively receiving an HCBS service, will you have to complete this form. Does anybody have any questions on that? Okay, go to the next slide. Health home billing policy, this was an annual review. However, we did have a couple of updates to it. One of those updates was going to be that we added a definition for fraud, waste, and abuse. We had to add language around this to meet OMIG standards. As many of you know, we are going through an OMIG audit, but there has been some updates to our workflow to be compliant. One of those things was adding that definition in there. I've also updated the CANS language in the billing policy to reflect the CANS 2.0 terminology, just so it matches, because we're no longer using high, medium, low acuity. We've now moved over to the complexity language, so the policy has been updated to include that. And we've also written out a process for overpayment. Again, this was to meet OMIG standards, but it also kind of lines out for all of our CMEs that should a claim need to be voided, or if there's an overpayment of some type, what the process here is at the health home to cover that. So Courtney is going to walking through that on the next slide.
Thank you, Jessica. Courtney, you're up.
Hi, everybody. So the process for the overpayment, is once it's been discovered that, there's been an overpayment. So if you guys change the rate code, and I know you guys do this sometimes, you'll bill the wrong, you'll answer one of the questions wrong. So that will change the rate code. So you'll email me and say, I changed the rate code, changed the claim. And what I'll do is I'll go in and I void that claim and I will resubmit the correct claim. And then the MCO will do a take back of the previously billed rate and then repay the corrected rate code. I know you guys have seen that before. If you did bill for a claim and then later on discover that it shouldn't have been billed and you void the claim, then I also void the claim and the MCO does a take back for that claim as well. And you, obviously, if it was non-billable, you would get payment for that. I think that's it.
Any clarifications anybody had around that process as far as what Courtney just described for, any claim adjustment or overpayment, how that works and the why behind it? We also have to disclose, it's a requirement that OMIG put in place as of last year. We have to, on a monthly basis as a lead, all health homes have to actually do a self-disclosure report. We do what's called an abbreviated self-disclosure report monthly for any overpayment scenarios, and we have to submit that to OMIG, and then they either respond or not respond to that report that we submit. To date, we haven't had any response, knock on wood, but we have over the last few months had submitted reports on some adjustments that we've made. So it is a thing. It didn't used to be a thing, but it is now a thing that happens monthly if we do have adjustments that have to be reported.
Travis, I was just going to ask you that because I know there was some scuttlebutt about that, I don't know, 6-9 months ago for the voided claim. So you are reporting those?
Yes. Yep. We're required to report them. I think was it by the 5th of each month, correct, Courtney?
I
We
believe
send
so.
that in.
The 5th or 6th, maybe.
Yeah.
But we do them like the week before, just, so that we have them done.
Yeah. So Courtney pulls a report. She keeps a running log each month for any of those overpayment adjustments. And then we funnel that through our chief financial officer and our chief compliance officer. And there's a review that's done, and then it goes out through our chief compliance officer out through to OMIG. He submits to OMIG monthly when we had actually last month no overpayments to report, so we didn't have anything to report. But the 2 months prior we did, so it would go out through his office. And there's a link through the OMIG website where that occurs, and you have to fill out this abbreviated self-disclosure form. If there was a certain threshold, then it would go up to the full disclosure form, which is a much more lengthier process. But fortunately, we haven't gotten to that, and hopefully we won't get to that point.
Yeah, and we haven't had that many either, Travis. Only a handful since we had to start doing it.
Yeah, so it's we have a pretty good system overall, thankfully, and as a network, we've done a nice job as far as getting the right codes billed at the right rates overall. So thank you all for doing that and being diligent about it. It makes life easier as far as reporting goes, when it gets to the other end of things. And we also have to report this through a compliance committee that we developed, which was an OMIG standard that came about. I think we spoke about it last year as well when the new regs came out through OMIG. We developed a health home compliance committee last fall, and that committee's met three times now. Two times now. Once late last fall, and then once this winter, just this last month. We created a compliance committee charter. So it's a legit thing, and it reports. This committee has a link to our compliance officer that reports up through our AHI board. So things such as the self-disclosure through OMEG that reports up through this committee, et cetera. So it's a legit process that all ties in, that's required through OMEG, through regulation and standard. So yeah, so that all kind of stems from this whole billing process, at least one aspect of OMEG anyways. Any other thoughts, questions around overpayment stuff? Well, we got Courtney on the hook here. No? All right. Thank you, Courtney.
You're welcome.
Jess?
And if you guys have questions, you can always email me.
Jess, we're back to you.
All right. So moving on to the Health Home Plus policy for SMI and AOT. This was also an annual review of this policy. The one thing that we did add to this was the list of diagnosis codes for SMI. We had been getting a lot of questions, which we don't mind, but I just noticed a trend where we're like, oh, does this diagnosis qualify as an SMI for Health Home Plus? So what I decided to do is just take a screenshot out of what's listed on the OMH DOH website for Health Home Plus, and I just went ahead and I put that right in the policy for everyone's reference, just to kind of help with any of that confusion. I know I look at it often when I'm auditing somebody and I'm like, okay, they have a diagnosis of this. Is this ineligible for SMI for Health Home Plus? So we just went ahead and added those codes right into the policy for reference. Does anybody have any questions on that? Okay, we'll go to the next slide.
I just wanted to mention, Jess, before I go to the next slide, back to that charter that I referenced for compliance, that actually is going to be a link through our Health Home website page in the very near future. So if anybody is so desiring to take a look at that for your reading pleasure, it will be up in the near future. We just have to work with our third-party vendor to get it up on the link, but it walks through all the stuff that we'll be responsible for as a lead health home as far as that committee requirements go for OMEG and the actual compliance committee.
All right, moving on to notice of decision and fair hearing. This was an annual review of this policy as well. We just updated some language to just clarify, just to try to be super clear on when you would send the 5235 and when you would just send out that agency letter and when you're going to need both. We also added one line in there that if someone files a fair hearing and they file for aid to continue, the lead can actually challenge that request. So we did get some clarification from DOH on that process. So now we've just included just one line in there just stating that the lead can challenge it. It would really be up to, it would be very case specific that we would review and then decide to challenge that continuing aid. And then as stated earlier by Travis about that compliance committee for AHI Health Home, we do meet quarterly, and one of the things that we do review quarterly will be the fair hearings that have been filed. So those are just a couple updates on this policy, but overall, everything pretty much remains the same. Did anyone have any questions on the notice of decision and fair hearing policy?
This is Sarah. I don't have a question as much as I guess a comment. Courtney and I talked a little bit about this. We had a case last week where a client assaulted one of our staff, and I wanted to be able to sort of immediately discharge and disenroll that person. And the 5235 still had to be sent out, and it would just be nice if there was room to talk about that, because I just feel like there are certain circumstances where we should, as a CMA, be able to say we are not providing services any longer. So I guess I just wanted to bring that up.
Yeah. So thank you, Sarah, for bringing that up. So this is going to be kind of a case-by-case basis on how we approach each one of the members that we run into this issue with. We have to send that notice of decision, because if you did not send that notice of decision and you just disenrolled them and that member filed a fair hearing, we would lose automatically. The first thing that they would look at, and they would immediately overturn the decision to disenroll. So just because you send the 5235 and you have to wait that 10 days before discharge does not mean that you have to meet with that client or provide any type of service during those 10 days. But we do have to follow the current policy that is written into DOH policy and can be connected back to CMS. So we do have to follow the 10-day rule. That does not mean during those 10 days you have to see that member and or provide any type of service. What would happen is, let's say you do that within 10 days and he files a request to conference with the lead health home. We would meet with him at that point. We would discuss what was going on. We would make kind of the determination to either stand by what you have determined or we could overturn it. He could also at the same time file a fair hearing in conjunction with that at the same time and file for continuing aid. All of those things would be on a case-by-case basis, and as soon as we were made aware, we would loop in the CMA. That does not mean that you would be mandated to continue to serve somebody who had assaulted one of your staff before. But paperwork-wise, we do have to follow what's in policy for paperwork. And then kind of how we approach it after that would be specific to that case. And then as soon as we were made aware of anything that was filed, or if he notified the health home in any way, we would reach out to you to have a discussion.
Yeah, I mean, that makes sense. I guess there's just frustration, you know, and I don't know how any of the other supervisors feel, but, you know, for us, we're still, I guess, have some liability for that case for the next 10 days, right? So this person is not doing well in the community. Everybody in the community knows that he's associated with us. They all are calling and sort of still wanting there to be intervention. And if there was some sort of a large community event with him, you know, where we ended up having to do an IRAMS or something, it just seems like the policy that DOH is creating gives us very little say or protection for our staff and is all about the client. And it would be nice to see that it was more that both sides were taken into account, because I feel like leaving this case open for 10 days gives us some liability. And maybe that's not how it would be viewed, but it's just how I feel about it, I guess.
Yeah, I think you
I
raised.
agree.
Yeah, I'm sorry,
I
Jess, go
agree
ahead.
with everything that you're saying, and this has come up before, and we have talked to the Department of Health about this as a group of health homes, because in any other kind of provider service industry, if he behaved like that at his primary care office, his primary care could drop him. If he behaved like that at a counseling appointment, his counselor in that facility could drop him. Really, when it comes to health home, we're not awarded those kind of same luxuries. So we have talked about this with the Department of Health. It is on their radar. And they've said that they're going to be modifying this policy. I have yet to see a draft version of this policy, so I cannot speak to what modifications are being made. But the exact concern that you have, Sarah, is a concern that we have right here at AHI, because we're serving someone internally that we have concerns about, and we're being kind of forced to continue to serve them. And I know it's a concern amongst many other health homes, and it is a topic of conversation. So we are representing kind of everyone in this instance with those same concerns. But we'll just cross our fingers for those 10 days in the meantime.
Yeah, and to Jessica's point, you know, I think, you know, we'd be mindful that, you know, the policies as such right now, but that doesn't preclude you as an organization to take steps to look out for the best interests of your staff. So if it's a health and safety concern, that's first and foremost, right? So if you had someone that was, let's say, was assaulting one of your staff, then there's measures you could take as an organization as action if you so chose, and the staff could take measures as well if they so chose. So, those are things that would have to be decided within your own organization. I think we have to look at that, from the best interest of what does the agency want to do for their staff at that point, as would we in our own organization through AHI or through the lead health home if there was a circumstance that arose. The 10-day letter, it's a formality. In this circumstance, I think if there was violence involved in a situation, I think it very much would be a formality. And if you could have that documented and showing that, steps were taken to protect the staff that was being assaulted, if that were the circumstance, and that the letter was sent because it was a requirement, but other actions were taken to help protect the staff and others involved. You're doing your due diligence at that point. And I think there's nothing more that you can do at that point than do your due diligence. And we as leads across the state have argued that point, as Jessica had indicated, and we're hoping that policy does change. Michelle had her hand up. Do you still have your hand up, Michelle? Yes.
I do. Thank you, Travis. I was just going to say, in addition to what Sarah was saying, and Jess was saying that a primary care can discharge right then and there. And these guys are not in these people's homes like we are. And so I know that you guys advocate for us. And I will say, we've certainly experienced some of this too. And I personally feel very grateful for the support from AHI. Unfortunately, it feels like this is more prevalent now more than ever before. And it's just very nice to have your support. Not that we don't in other health homes too, but I can speak from my own personal experience that I am very grateful to be associated and contracted to AHI, because I do know that you advocate for both parties and are willing to look at things on a case-by-case basis.
Thank you, Michelle.
Yeah, absolutely. Yeah, and we work, again, we talk about a case-by-case basis. Unless you're serving a Health Home Plus member, there's no requirement to see that member in person. And if they are Health Home Plus and you do have to see them in person and there is some sort of safety concern, there's always ways that we can kind of work around it to protect everybody. And again, staff safety is the most important thing, and that's something that we talk about often. So if you're ever struggling with a client and you're not sure what to do, and you know that you feel that you can't just discharge them for whatever reason, to please reach out to us and we can definitely work through that. And I do agree, Michelle, this is more prevalent than ever. We have seen more instances of this over the last 12 months than I have in my entire career with Health Home. So it's definitely on the rise, and I definitely want to make sure that we hear you, and that if you do have a case, something that you want to talk over, that you do reach out to us.
I think Lori had her hand up. Lori?
Yeah, I just want to chime in, and maybe I should just be quiet, but I mean, for myself, where I work, if one of our staff were assaulted by someone, number one, we would pursue legal charges, because that's just part of natural consequence, whether somebody's ill or not. Whether they're Health Home Plus, AOT, from a director standpoint, my staff would not be going out to see them, period. I mean, so we don't get paid that month. I think that there is plenty of justification that staff safety is number one. There are steps you can take at the time to try to ensure that, all the parties who need to be aware of the incident that happened, one for the staff safety as well as the clients, if they're that out of control. But beyond that, that would be the end of it. We would just merely wait for the 10 days to elapse and go ahead and close them. I mean, whether the state expected us to go see someone or not, we would make sure they're well aware, of what's going on, and the authorities and clinical providers, but that would be the end of that.
Yeah, and I guess just to clarify, we certainly did all of those things and we have no intention of providing services. For me, it was more, wanting to have a route to immediately discharge the person and not have to wait the 10 days. I mean, in terms of authorities, that's not an agency. And, for us, that's up to the individual who was assaulted. I can't tell him to press or not press charges, but it's at least nice to know that it's a conversation at the state level. So thank you, Travis.
Yeah, oh, absolutely. And it's, and every organization's different and there's folks that, to Lori's point, there's a stance at certain organizations where this is the action that's taken, period. There's the people that have a lower tolerance that are doing the work directly with folks that we're working with that'll press charges immediately. Others won't. So it comes down to the individual. I think the bigger discussion is the health and safety and well-being of everyone, right? So at the end of the day, if this is more and more a topic of discussion for people's safety and concern for safety, there needs to be a global discussion and it needs to be looked at more closely. And, and it is at the state level. The Department of Health, Health Home is well aware. It is being advocated for. I think mental health crises is more and more prevalent than it has been in many years. And there needs to be more action to support people out there doing the work to help others who have mental health concerns. And, unfortunately, the processes and paperwork that have been in place have been there for a long time, and a lot of them are dated and they need to be caught up, or abolished and removed. and so, that's the challenge that we're facing a lot of times. And but I think as a lead, getting back to Jessica and the points that she was making, we want to hear you. We want to work with you because we're not, it's not a factory. We're not working with widgets. People are complex. It's not black and white. Everybody's circumstance is different. There's a lot that makes us each unique and individual. So each circumstance is going to have to be dealt with differently in many situations. So we want to work through that when we can, and we may not always have the answer either. That's the other thing. But we'll do our best to help support the situation. But the paperwork piece, there's only so much we're going to be able to do with that. But we can work around it in certain ways, like Jessica suggested, and then be on our way. It's a good discussion. I think there needs to be more action clearly around it. Thanks for bringing it up, Sarah. Anybody have anything else on this topic before we move on? Hey. All right, Jess.
All right, switching gears to incident policy, incident reporting. We have just done our annual review of this policy. There was no real big update to actual policy. The only thing we included in here is, again, back to that compliance committee that we have here at the health home level. We meet quarterly, so not only are we reviewing all of the fair hearings that have been filed against us, complaints and grievances, but we're also going to be reviewing incidents that have been submitted over the last quarter as well. That was the only change to this policy. Does anybody have any questions on anything regarding policies that we went over today? All right. Switching to children's program updates. Just wanted to send out a reminder to everybody that if you have a level of care coming due, it has to be completed. This is for the HCBS population for children. If they're due for their level of care, it has to be completed on the 365 date to the due date and or a couple days prior to that. If your annual level of care is not completed on time, you will not be able to bill for that month of service until it is completed. The reason I'm bringing it up is that there is no billing block in the system. I have to manually check, and then we'll have to void billing for that month. So if you have a coming due level of care, which we do have quite a few, apparently April and March were a very busy month for level of care. Make sure that those are completed on time. The other thing is to make sure that you are completing that supervisor level of care sign-off form before you complete the level of care. And please send that to the health home for my review before you complete the level of care. This will prevent any kids having a level of care completed in the UAS that are not eligible to have one completed. So if you guys have any questions on any kid that's coming due for their HCBS level of care, please reach out to me. And I have emailed everybody that is coming due in, I want to say March and April. So if you think you have someone coming due and I have not emailed you, please reach out. Again, if you have any questions regarding HCBS or getting these levels of care completed, please let me know. We will be audited again for this population in probably sometime late June or July. So I just want to make sure that everything is completed correctly prior to that level of care being done. Does anybody have any questions on that? All right. Do you want me to take this one, Travis?
Sure.
All right, just a reminder to everybody, or maybe possibly new information. So when we put members into NetSmart, when we get a referral, or let's say we put them the segment in MAP, whenever someone initially comes into NetSmart, we are pulling over their insurance information, and their insurance information pulls on the left-hand side under the eligibility tab. I know when we say eligibility, we're talking about something else, but in NetSmart, left-hand side, there's an eligibility tab. That's actually the member's insurance. That is put in initially when that member goes into NetSmart. So let's say you're working with a member and they recertify and their managed care company changes, or they go from fee-for-service to managed care. Once there's a change in that member's insurance, it's the care manager's responsibility to then update that eligibility tab in NetSmart. Otherwise, that tab will be outdated. If the tab is outdated, it doesn't affect anything. It doesn't affect billing. It doesn't really affect anything other than kind of referencing it to be accurate for accurate information. But we do it initially here at the health home, either manually or through the MAP import. But if something were to change, it is the responsibility of the care manager to update the information on that tab. Does anybody have any questions about that? All right.
All right. Thank you, Jess. Just wanted to give an update on the plan of care upload status. So we're fast approaching a 3/31 date for that billing block to begin. So DOH will start to put that block as we move forward. So just so folks know that Health has been actively doing the MAP upload for the plan of care uploads from NetSmart on a weekly basis. I know in the last week and a half or so, we've been reaching out to supervisors on some activities to get some things inputted manually to work toward this deadline. So we thank you all for doing that. We have throughout the month of April to ensure that every last nook and cranny is taken care of, because remember, billing goes back to the first of the month when we're looking at MAP as far as that goes. So we're in pretty good shape overall, but we've got a couple of loose ends as far as the consent dates and signature dates, social support contact information, which I know a lot of people have been inputting. I think we had given through tomorrow just to try and get that stuff in. And I believe it was Jessica and Taylor had sent out some lists late last week for remaining folks to get inputted. So thank you for those of you that have been inputting remainder for folks doing that. But we're really looking at people who have social supports. For a child, you really have to have a contact in there for social support. If it's an adult, it's not required, but if there is a social support in there, there's got to be an address and a phone number that's got to be entered for that active contact. If the member's not willing to provide social contact address or doesn't know it, you can put your agency's address. If they don't know the number or are not willing to provide a number, same thing. You could put in ones, and that'll allow it to go through at this point. That's something that NetSmart had said that'll push it through to MAP for the upload. Didn't know, Jess, was there anything else we wanted to mention around this that I missed?
I don't think so, but Lori did have her hand raised.
Oh, did you? I'm sorry, Lori, missed you.
No, that's okay. I raised it, but you sort of answered it by the agency address.
Oh, okay.
Sometimes what I've been doing now, and I guess I had started this a week or so ago. I put, like, if I know the parent or and these are for adults, the person lives in the city of Glens Falls, but we don't know the actual street address, I'm putting unknown under address and then putting Glens Falls, New York. Is that enough that it'll fly because there is something at least on the address line?
I'm gonna have to
Yes.
defer.
Yes.
It will?
Yes.
Okay.
Yep.
As
So I'm
long as
not-
there's something in the fields.
Okay,
All right.
beautiful.
And then
Courtney's,
just update it when you get the correct information, obviously.
Gotcha. Well, we have some families that will not tell their adult mentally ill children where they live, so
yeah,
Okay.
it may never be updated.
Yeah, then that's fine.
we know it's not a perfect science, but unfortunately, the way MAP's got the spec document built, it's just making it impossible. So some of the stuff we have to work with NetSmart in order to get it to so it successfully goes through. So that's why this sort of thing's coming up the way it is suddenly to make it all work. But as you're going in, if folks, as you're able to get the correct information in, if the member's willing and able to give it to you as you move forward, then please do so. But for now, for time's sake, if they're not able to or don't know, this is our way of getting it in there. But for just for folks working with children, though, we've got to have information for social support contact. Adults, we have it now if they don't have one listed. Anything else, Courtney? I know Justin have anything else. Anything else that we missed, Courtney, on social support?
I don't think so.
Okay.
Is
Alright.
NetSmart gonna make possibly push an update to make this a required field? So care managers
Yes.
in the future, don't forget.
Yes, we're working on that with them.
Awesome. Thank you.
Yeah. Yeah, that's one of the things for our discussions. Yes, short answer. But thank you all for this last minute push. I understand it's inconvenient. We realize that fully. So a big thank you. I know we gave a quick deadline of tomorrow, but we also want to have a couple days so that we can be proactive for any last minute adjustments. But if something does bleed over early into next week or so, it's not the end of the world. We'll still have an ability to do some adjustments into the early part of the month. I just don't want it to be an onslaught of things that we have to adjust. So the more we get done now, the better things will be as far as being in good shape. All right. Any other questions or comments around this?
Travis, I just wanted to add, for the adults, since they don't necessarily need the social support contact, if it's something that's irrelevant, at this point to that member, you can make, the support inactive, and that will eliminate them from trying to pull on the file and, erroring out if they don't have a phone number or an address.
All right. So you can make them inactive. Thank you, Taylor. All right. Assess tool, the next billing block. Just a reminder that's coming the end of May. We talked about last month that that is something that DOH did put in place, that we're gearing up for that now. I think we successfully have roughly 600 that have gone through that we've uploaded. So it's a pretty good chunk since November timeframe started. We talked last time that we're not going by the comprehensive assessment date any longer. So because of the billing block going into place, that kind of altered things from our original game plan. So now we're going by the month of enrollment. So we want to go back and look at that. So if folks would go back into that time frame of November and start going back and looking at it from that and moving forward, and making those adjustments and doing the assess for those folks that would have been due at that point for month of enrollment. And then we'll be in good shape. We got a couple, we're going into April, May, so we got about 2 months left before that block goes in. So there is some time to catch up on, those adjustments, and we'll move forward. So just more information, what I just described. Just want to remind folks we're not going on that annual comp assessment anymore for the due date. Any questions or thoughts on this? Any more clarification anybody wanted? Okay. Taylor, do you want to talk about how we can help assist with that, with the data?
Yes, I'd love to. I know
Okay.
we shared this slide during last month's office hours, but I just wanted to reiterate that this initial assess tool due by month report is available in DataDen. It's going to show you any members you have that have been enrolled for 12 months or longer and do not have assess tool complete already. I just want to encourage everybody to use this tool and filter on all months back to November in order to get the assess tools in and complete before that billing block goes into effect. We did run a report yesterday or the day before, and there is a pretty significant chunk of assess tools still missing. So Jess and I will be compiling that and sending that out to supervisors, but you guys do have direct access to the same report through DataDen. So don't be shy to go in and take a look and get those assess tools in. And then same goes for the eligibility screening. So this one is particularly for status changes. So as you guys know, we now have to do a new eligibility screening for adults and children when they come out of appended status, so either excluded setting or DSE. And when they move back to enrolled, they need a new eligibility screen within 30 days. So there is a report in DataDen now that will track those members for you and provide you with the date that is 30 days from the day that they re-entered into an enrollment status. Thanks, Travis.
Yes. And this is just a reminder around the eligibility and appropriateness criteria. I just highlighted this. This was a slide from the last couple months, just a little redundant, but just want to keep it on the forefront for folks. Taylor had just mentioned, if there's a status change, that's got to be done, or there's going to be rejection of billing. So an example would be person was DSC back to enrolled. So just want to make sure folks are aware of that. Any questions? Any questions around those tools that Taylor just went through DataDen? All right. And then budget advocacy. I want to thank everybody. I know we were forwarding quite a bit of stuff over the last couple months now anyways, around the budget. One House budget bills, Senate and Assembly both asked to have the cuts restored through Health Home. So the latest and greatest is I had sent out in the last week was this actual SALSA campaign letter, I should say, thanking all the legislators for keeping that noise up and basically keeping it on the forefront for the final discussion and negotiations to get that reinstated back in the budget. So we're keeping our fingers crossed. A lot of advocacy's gone in. So we're very encouraged at this point. So stay tuned, and you know, we're hopeful that that 125 million gets put back in. And then Jessica had a reminder that there's a training on 4/12 at 11 o'clock, problems and eligibility training. An invite has gone out for that training. Jess, when did you send that out?
You know, I don't know the date that I sent it out. It was probably about a month ago.
Okay.
So if you didn't get it, please email me and I can forward it to you. I did send it out to all the supervisors, so the supervisors have it, and then you can forward it to your teams.
All right. So if anybody didn't get it, let us know and we can make sure that we can get it to you. So 4/12 at 11 o'clock, problems and eligibility training. And that's all we had for today. Anybody have anything else they want to talk about? Any questions, anything? Well, if not, as always, thank you for all that you all do, and I hope you all have a great rest of your day, and we'll talk with you soon.
Thanks, guys. Have a great day.
Bye.
Take care.